hand and wrist is demonstrated in the video program on the physical examination of the hand and wrist. Cervical region, sternocleidomastoid, 11th cranial nerve or spinal accessory nerve. With the patient sitting, stabilize the thorax with one hand and instruct the patient to flex the neck while resisting with the palm of the other hand against the forehead. Then remove the hand from the thorax and carefully palpate the sternocleidomastoid muscle on each side. The sternocleidomastoid can be tested individually by instructing the patient to turn the head to one side against the resistance of the examiner's hand. Stabilize the opposite shoulder to prevent trunk rotation. The opposite sternocleidomastoid is seen to stand out and can be palpated by the examiner. Lateral bending and extension. The power of lateral bending and extension of the cervical spine should be assessed. Note that many muscles or groups of muscles are involved and they cannot be individually assessed and palpated. Lateral bending. Stand at the side of the patient and stabilize the ipsilateral shoulder. Instruct the patient to bend the neck laterally while applying resistance to the lateral aspect of the skull. Muscles involved in lateral bending include the scalenus anterior, medius, and posterior. Extension. Stand behind the patient and stabilize the posterior upper thorax. With the other hand over the occipital region of the skull, resist the patient's attempt to extend the cervical spine. The trapezius muscle as well as the posterior paravertebral muscles, including the splenius, the semispinalis, cervicus, and capitis, are functioning during the act of extension. Shoulder region. Scapular elevation. Trapezius, 11th cranial nerve or spinal accessory nerve. Stand behind the patient and place each hand laterally over each acromion. Instruct the patient to shrug the shoulders up towards the ears while applying downward pressure on the acromions. Since the shoulder shrug maneuver involves several muscle groups, a discrepancy in strength between the two sides may denote weakness of the levator scapulae, C3, 4, rhomboid major and minor, C5, as well as the trapezius muscle. Scapular retraction, rhomboid major, rhomboid minor, C5, dorsal scapular nerve. Stand in front of the patient and grasp each shoulder region with the thumbs anteriorly and the fingers posteriorly. Instruct the patient to force the shoulders backwards, as in assuming a position of attention, and attempt with your fingers to rotate the shoulders anteriorly and medially. This maneuver tests the retractors of the scapula, namely the rhomboids major and minor supplied by C5. Serratus anterior, C5, 6, 7, long thoracic nerve. To test the serratus anterior, instruct the patient to push against the wall with the arms in an extended position. Normally, the medial border of the scapula will remain flat against the posterior chest wall. But if the medial border protrudes away from the chest wall, this denotes weakness of the serratus anterior and is called winging of the scapula. Flexion. Primary flexors. Anterior deltoid, C5, 6, axillary nerve. Coracobrachialis, C5, 6, musculocutaneous nerve. Immobilize the scapula by placing one hand over the top of the acromion in such a position as to be able to palpate the anterior aspect of the deltoid muscle. With the other hand, grasp the anterior aspect of the distal humerus and with the elbow at 90 degrees, apply resistance as the patient is instructed to flex the shoulder. Extension. Primary extensors. Posterior deltoid, C5-6 axillary nerve, latissimus dorsi, teres major. Continue to stabilize the scapula by pressing downwards on the acromion. While applying resistance to the posterior aspect of the distal humerus, instruct the patient to push the arm backwards or into extension as you palpate the posterior aspect of the deltoid to assess the tone of the contracting muscle. Abduction. Primary abductors. Deltoid mid-portion, C5-6 axillary nerve, supraspinatus, C5-6 suprascapular nerve. Apply resistance to the lateral aspect of the distal humerus as the patient is instructed to bring the arm out to the side. Continue to stabilize the scapula by downward pressure on the acromion and palpate the mid-region of the deltoid muscle. Adduction. Primary adductors. Pectoralis major, C5 to T1, latissimus dorsi, C6 to C8. Apply resistance to the medial aspect of the elbow region as the patient attempts to force the arm into the side of the body. While maintaining stability of the scapula, the examiner can palpate the pectoralis muscle anteriorly. Internal rotation. Primary internal rotator, subscapularis muscle, C5-6 subscapular nerves. With one hand, stabilize the elbow at the patient's side and with the elbow flexed to 90 degrees and the forearm in mid-pronation supination, apply resistance to the distal volar forearm as the patient attempts to bring the forearm across the front of the abdomen. External rotation. Primary external rotators. Infraspinatus, C5-6 suprascapular nerve, teres minor, C5 axillary nerve. Maintaining the patient's arm in the same neutral position, apply resistance to the dorsal aspect of the distal forearm as the patient attempts to turn the forearm away from the body. The power of all of the muscles or groups of muscles should be recorded, and comparison with the contralateral shoulder is imperative. Elbow region. Flexion. Primary flexors, brachialis, C5-6, biceps, C5-6, musculocutaneous nerve. Secondary flexors, brachioradialis, supinator. In order to test elbow flexion, the forearm should be in the supinated position. With one hand, stabilize the lower end of the humerus posteriorly, and with the other hand, apply resistance to the volar aspect of the wrist region. Instruct the patient to flex the elbow against resistance. Compare the muscle grade with flexion of the opposite elbow. Extension. Primary extensor, triceps, C6 to C8 radial nerve. Secondary extensor, anconeus. Maintain the same position as when testing flexion, but this time apply resistance to the dorsal aspect of the wrist region while instructing the patient to extend the elbow. Compare the strength to the opposite elbow and record the value on the muscle grading chart. Supination. Primary supinators. Biceps, C5-6 musculocutaneous nerve. Supinator, C6 radial nerve. Secondary supinator, brachioradialis. Stabilize the distal humerus posteriorly and maintain the elbow at the patient's side to prevent any shoulder motion which may be used to substitute for supination. With the forearm in the pronated position, grasp the distal forearm with your other hand and while applying resistance over the dorsal aspect of the distal radius, instruct the patient to supinate the forearm. Pronation. Primary pronators. Pronator teres, C6-7 median nerve. Pronator quadratus, C8 to T1 median nerve. Secondary pronator, flexor carpi radialis. Again, stabilize the elbow at the patient's side and grasp the distal forearm in a manner to apply resistance along the volar aspect of the distal radius. Instruct the patient to begin to pronate the forearm from the supinated position while applying resistance to the distal volar aspect of the radius. Pronation and supination can also be tested by grasping the patient's hand and applying resistance to pronation or supination through the hand. The examiner is cautioned, however, that pathology in either the hand or the wrist region could interfere with the results by diminishing the value of the muscle grading obtained. Deep tendon reflexes. Biceps, C5, brachioradialis, C6, triceps, C7. Biceps reflex, C5. Rest the patient's forearm across your forearm and palpate the biceps tendon in the antecubital fossa with your thumb. The biceps tendon can be easily located by asking the patient to flex the elbow. After locating the biceps tendon, however, assure that the patient's arm is completely relaxed before attempting to elicit the reflex. Strike your own thumb over the biceps tendon with the reflex hammer, and in the normal patient, the biceps muscle will jerk. This movement of the biceps can usually be seen in the thin patient, but with a more obese patient, the presence of the jerk will be appreciated by your thumb on the biceps tendon. As discussed in the neurological examination of the lower extremities, an increased deep tendon reflex suggests loss of inhibitory function of the brain or an upper motor neuron lesion. A decreased or absent deep tendon reflex suggests pathology in the reflex arc or a lower motor neuron lesion. Brachioradialis reflex, C6.